Good afternoon. I'm Ajisafe, and I'm here to present my afternoon report entitled Appears Clinically Well. So the chief complaint was a 28-year-old female presenting with shortness of breath and lower extremity edema. Classic. History presenting illness. 3 weeks before she came to the hospital, she started feeling short of breath during normal activities, only being able to walk 3 blocks before needing to catch her breath. Before, she used to be able to walk indefinitely to New York. Then after 2 weeks of this, she went to a pulmonologist where she got a chest x-ray, and she says they found something hazy. And because of this haziness, they gave her prednisone and cefuroxime. The next day, she noticed that she had swelling in both of her feet, and she thought it was because of prednisone and cefuroxime, so she stopped taking it. And she also noted that 3 weeks ago, before the shortness of breath, she got a new humidifier and was using tap water for it, and thought that could have been the cause, so she stopped using it. Otherwise, she endorsed the vague past major serious and valvular issue, then denied any chest pain, chest tightness, leg pain, OCP use, travel, malignancy, immobilization, surgery, sick contacts, diet change, weight change, smoking, drug, or alcohol use.
Yes. You want to go back to your previous slide? I feel like there's a lot of information there. All right. Does anyone have any questions? I know I had a few. I did hear this case before. I had a few when I first saw this. Does anything catch your attention here? Whether it's, yeah, there you go.
So she only took the prednisone for 1 day, is that right?
For 1 day.
And she didn't have like any. Did she have like any fevers, chills, cough before this, or was it just the shortness of breath?
Just the shortness of breath.
Was this like vague valvular issue since she was a kid, or?
She wasn't able to elaborate, saying just in the past something with her valve.
The dyspnea, is it worse like on exertion? Is it like at night? Or...
It's worse on exertion. When she was walking, she would notice she get tired more easily.
Did she get any like, it's too specific, but cyanosis, or does she know she get purple when she was younger or something while exerting herself?
Not while exerting herself, no cyanosis, and no mention of when she was younger either.
Was she good about cleaning her humidifier?
Did not come up in conversation.
No one is good about cleaning their humidifier.
She's using tap water, and we don't know why she's using a humidifier for. Like, it started before she developed the shortness of breath, that someone said you should use a humidifier with tap water for something. We're not sure, right?
Right.
She's not a great historian. And her primary care doctor saw something. We don't have the x-rays. They saw something and they immediately started her on prednisone and cefuroxime. Can anyone tell me maybe what the thought process was? What do you guys think? If you see a patient walk into your primary care clinic or your subspecialty clinic, they bring this prescription.
This like necrotizing pneumonia, but you treat that with steroids. That was my first thought. Like this, it's now called like it's now called BOOP or something, cryptogenic organizing pneumonia.
Yeah, I would think an organizing pneumonia, but it'd be kind of strange to not have that from a CT and just an X-ray.
Like some sort of acute exacerbation of asthma. If they weren't sure, maybe they treated maybe a pneumonia plus or minus asthma exacerbation just to hedge themselves.
Okay, some more common diagnosis. You have to, yeah. And you're thinking maybe I need more, of a workup to decide what happened with this patient, but suboptimal historian, we don't have the records, even though we checked that little link on Epic that leads us to like all prescriptions and records, we couldn't really find anything there. Okay. And of course, the valvular issue that we don't really necessarily know much about. In this patient, someone comes in and they're telling you, well, there's something a history of a valvular issue, what things do we ask this patient? Common things being common. About her personal history, or family history, or demographic.
IV drug use.
Come again, Omar?
Any IV drug use, any history of valvular surgeries.
No IV drug use. She denied any previous surgeries.
It's important.
So say one more of the background history. In terms of past milk history, there was only this previous valve issue she couldn't remember, and she denied any previous surgical histories. She had no relevant family history, no CADs, MIs, CVAs, CHF, or aneurysm, and social history, no alcohol, tobacco, or illicit drug use. Allergies, there's no known drug allergies, but just a shellfish allergy, and she takes no medications and nothing over the counter either.
So nothing similar in her family history related to the heart. Where did you say the patient was coming from?
Patient was coming from home. She's living in New York, Manhattan.
Born and raised.
Unsure where she was born, but she's been raised here for the last 10 years at least.
Any recent travel anywhere?
No recent travel.
And you went through the extensive review of systems, but do you mind remind? Okay, there you go.
So for the review of systems, she had no fever, no congestion, sneezing, trouble swallowing, no change in her vision, positive for the shortness of breath, positive for the leg swelling. She endorsed she made a large amount of urine in the morning, and that she's also on her menstrual period, and she normally has heavy flow. Otherwise, no gait problems, no rashes, no dizziness, no nervous anxiety, no abdominal pain or chest pain. Any questions?
So leg swelling, bilateral.
Bilateral.
Anything else you need to know about the leg swelling? Any other descriptors? And I guess we can do a physical exam later, but let's say this is a telehealth visit, you can't really see, she can't point.
Yeah, you wouldn't know if there's like a rash, if it's painful, if it's pitting, if she can like press into it.
Non-painful, full range of motion, bilateral pitting edema below the ankles. So for the physical examination part, in her vitals, blood pressure is almost perfect, 119/80. She was tachycardic at 112, temp 97.4, rest rate 26, saturating 97% on room air, BMI was 18.2. She was 5'3", weighing 103 pounds. She was well appearing, no acute distress, she wasn't sweating, atraumatic, not subtle, no JVD, regular rhythm, but again, tachycardic with normal pulses and heart sound. She was normal effort, talking perfectly, talking comfortably, with bilateral crackles throughout the lung field, soft abdomen, no paresphenomegaly, MSK, she had full range of motion, non-tender with bilateral pitting edema below the ankles, and no neurological deficits, ANO ×3, cranial nerves intact, no tremor, mood normal, behavior normal, warm and dry, no pallor, no rash.
For a second. Can anyone give me the 3 main symptoms that the patient's presenting with, or however many you would consider? And what you're focusing on. I saw Victor taking a few notes there, which I think is wise, because there's a lot going on. So if you don't mind sharing the notes that you've taken, what has caught your attention so far, and what are we focusing on in this physical examination? Because we already know someone like youngish with like decreased functional capacity and some like something else. What's going on?
Do you want just like an overview about the history and physical?
I want to know which symptoms caught your attention. Now
I mean,
you're
so
seeing the
far-
physical exam. Yeah.
Yeah, I mean, so far, like the things that got my attention are exertional dyspnea, edema, most likely subacute in nature, and basically the physical exam findings like the edema and the bilateral crackles, and low BMI caught my attention.
That caught your attention as well. So there's a constellation of symptoms that could or could not be related. And you mentioned the timeline as well. You said subacute and sort of like refresh. How did they appear? And how could you link these symptoms? I know we don't have to have it right. We have very little information, but. What? Yeah.
I mean, just like general overview. I mean, if you want to categorize things into like different differentials, possibly you can think along the lines of, this is what I was thinking about, think along the lines of possibly something infectious, and then thinking along the lines for possibly autoimmune versus a pulmonary process. And the main read, like with a BMI of 18, I don't know what her mouth exam looks like or anything, but thinking about possibly I forgot, eating disorders and related comorbidities along with those could be something that we should keep in mind as well.
And you have Dayo here to answer that question. He will be
Great
your eyes.
question. There's no mouth ulcers, there are no mouth sores, and there's no Russell's dorsitis in the back of the knuckles either.
Swelling of parallel glands.
And no.
Yeah, I love how you're keeping it broad. Maybe one thing led to the other. Maybe there's some immunosenescence wherever, and maybe this could have led to an infectious process. And you're suspecting that because of some of the systemic symptoms, the shortness of breath, the hazy opacities that they saw in the X-ray.
I mean, I'm rotating an ID, so everything is infectious until proven otherwise. But today, like I learned something today, which is like a very low BMI and female population, like very old and very young, presenting with pulmonary symptoms related to water stuff could possibly be MAC, but
In the context of, and we'll have to ask several other questions to this patient if we want to
Yes.
know if maybe, and this is something we shouldn't forget, like our patients, we have to ask about their sexual activities as well as if there are any other risk factors. And again, like where they're coming from. And thank you so much, Victor, for sharing your thoughts. Dayo, I know you have so much more to share. Does anyone have any more questions about the physical exam before we move on? It's very specific about the concrete findings, but also about the negative pertinent findings, if you can see. There's no icteric tint. He did find crackles, but the patient is not distressed. It's pitting edema below the ankles, and from what we heard, it doesn't really change. No other deficits that we could tell, or rashes in her skin.
I would say like pertinent negatives. This is a young, I think she was female, right?
Right.
Like low BMI, she's tachycardic. I was thinking like thyroid, hyperthyroid for one. The neck is supple, there's no goiter or anything. So I think those are kind of important to keep an eye on.
Right.
Definitely. Go for it, Omar.
I was thinking also of like nutritional deficiencies.
Okay.
Reported no change in her diet recently and no unintended or intended weight loss.
Okay. We could still have some nutritional deficiencies, and you can see her neurologic exam is unremarkable, and her skin is not showing anything, but definitely we have to keep that in the differential. Yep. Go for it, Dayo.
So knowing she came in with shortness of breath for 3 weeks, one thing I have to think about is the approach to dyspnea, which we all love to show and share. This is a nice algorithm I like that shows there's 3 things to think about, whether it's the brain, whether it's the pump with the heart, the wall, and the muscles, or gas exchange occurrence, the alveolar capillary. This is multiple things it can be and multiple questions to elicit during the history as well. So you'll know in case it's COPD, if they have any smoking history, if they had this before, if it's heart failure, if they have any orthopnea, any dyspnea, any triggers for it to be asthma, if they have any infection, fevers, chills can do this, any thyroid issues as well. And then myasthenia gravis, neuromuscular junction related diseases can also have an effect on the chest wall and the dyspnea they're occurring. And this is just one way to think about it when you take a history, as well as the physical examination, what it's showing you. So the next part is going to be the labs you want to get. So any labs you guys would be interested in ordering for this patient. These are common panels you'll see at the ED.
Just a quick question. What does she do for a living?
Thank you.
I wasn't able to get that.
Oh, okay. Thank you. No.
Victor's still thinking about pulmonary exposures and other things. Fantastic. Thank you.
We definitely need to get the pregnancy test.
How so, Sidra?
You have a young female coming in. She's having dyspnea. She's having, edema. These are all signs that can be a pregnancy, although I don't recall her sexual history. We should just always
Great.
get one in that age.
Great.
She's engaged to her fiance.
Right. And even if your patient tells you that they're not sexually active, there's no possible way. If you have a high suspicion, maybe not necessarily in the case of shortness of breath, but let's say you're like, well, could it be like a rupture or anything else? There's a hemorrhage. You always take a test regardless of what your patient may say if your suspicion is high. Does it send the emergency department, Dayo?
In the emergency department.
Cool. All right. So we spent some money in the pregnancy test. What else will you guys want to get? Something that's
Definitely
Gonna
a
help.
CBC.
okay.
I mean, she could be anemic as far as me.
All right. Money well spent. All right.
CBC and pregnancy test. Is that all, or are we getting anything else?
We made our diagnosis.
Let's get a TSH.
Let's get a TSH.
Okay. It'll take a few days. Her goiter is normal, no tremor. She's mildly tachycardic. Could be. Autoimmune processes are common in that age. Sidra, you were going to say something?
Yeah, I was gonna say we talked a lot about possible nutrition, her BMI. I think we should check her lights.
Okay.
I agree.
Sounds reasonable. Yeah.
I think UA might be a good shot just for the protein. It's pretty cheap.
Ah.
Okay.
She's got pitting edema. I know we're thinking it's infectious, but just in case.
Will you do like a urine dipstick, or you can do like a collective bites? Or are you gonna?
I was thinking starting with a dip, and then if it's protein positive, you can do like an ACR, PCR, depending on what everything else shows.
Cool. That sounds like a plan.
Are we happy with all that for the moment? I think this sounds.
Anyone wanna? Yeah.
I'm gonna say a D dimer was probably sent.
Was probably sent, but will you have sent it, Tyler?
I think I would have. I wouldn't have jumped straight to a CTA, but like tachycardic, dyspneic, I wouldn't say like an acute PE since it was 3 weeks long, but
That's fair.
yeah.
You have several criteria that can aid you in, like, whether you want to get this or what the probability or the likelihood ratio is, right? Sorry, I go first.
So I called the case report appears clinically well, because by all means she appeared clinically well. She walked in, she was talking normally, and then these are what we saw when we got the labs. Anything look off? I can count at least 10.
What's that hemoglobin?
Yeah, 3.2.
Damn.
Call it out, but also specify. So the hemoglobin is low, but are there any other values in the CBC that can tell you a little bit more about this anemia?
MCV is really low.
The RDW is high,
What does that say?
like more towards iron, iron deficiency.
We have a microcytic anemia, hypochromic, with a
That's
higher.
a peripheral smear.
Okay. What are you looking at there?
I mean, we have marked schistocytes, ovalocytes, target cells, teardrop cells, just like a combination of everything.
Every step forward, all of them.
Does it give you any information, Dayo? You see a,
It can help you narrow it down as to what causes those marked schistocytes and ovalocytes, but still a lot of different differentials.
okay, fine. You see anemia, you see schistocytes. What is the next thing that you look at? What do you guys all went to look for in the lab so you have available?
Platelets.
Okay, great. And how are those?
They're normal.
What is the second thing that you look at? If you're thinking maybe this is, something's breaking in your vessels.
Oh, definitely. I mean, if we have bilirubin, haptoglobin, I don't see them over here.
Maybe we don't have those readily available yet because you're
Yeah.
still making your, this is your thought process as you're collecting labs. Maybe that's your next step in ordering. Okay, what else do you guys see? Is there anything else in her, in bone marrow that's abnormal? In her lines, in her cell lines? She has a leukocytosis, right? So she has a normal platelet count, anemia, and a leukocytosis. So we still have yet to explain. There's some schistocytes and there's something going on with her, now her electrolytes. Sidra, you had asked for your electrolytes because you suspected there might be some sort of nutritional disorder. What do you think about this BMP?
It looks terrible.
Right?
Her renal
So scary.
not good. Her GFR is 3. She's really hyponatremic. Her bicarb is too low. Just doesn't look good.
But she's walking and talking, and this has been going on for what, 3 weeks? How do you explain someone is just showing up because they felt, you know, mildly short of breath or they can't walk a couple?
She's young, so she's not, she would compensate, I guess.
All right, so we said this is subacute, but most likely looking at her labs, she has a hemoglobin of 3.2. There is no pallor on exam.
That's going to be hard to, you know, kind of, you know, live with that if it happened relatively quickly, no matter how young they are. That's really low.
Yeah. Go for it, Dyer. You're doing a great job.
There's a bit more as well. You wanted to VBG and UA. In case anything here jumps out as well.
And just to mention in the previous slide, because I know there's a lot, her BNP was also elevated, correct?
BNP was 7.6 thousand. Yeah.
And can I just ask, has anyone seen one that high? Because I've only seen like 1,000. I didn't even know it could go that high.
Is this a residence record?
I would say, yeah.
I'm amazed.
The CCU maybe. All right, so what are we looking at here? So who had ordered the, where are you, Joe? There we go. You wanted a UA. You wanted to look at something here. What do you think?
Yeah, so she's got lots of protein and some blood.
Okay.
So you'd want to know if she's on a period. Sorry, I can't remember if we already mentioned that, just to double check.
Yes.
But based on how abnormal everything else is, you wouldn't put it past it to be real. So then you're worried about something. I mean, obviously with a creatinine of like 3 million or whatever it was as well, you're like concerned about her kidneys anyway. So this kind of adds itself as a potential contributor to her volume overload. This plus or minus hot. And she's got bacteria as well.
You see, you guys know what the diagnosis is yet? Or do I need any more labs?
I would do
Did
a
you get, sorry. Did you get like Legionella antigen for her?
Which antigen?
Legionella? Urinary antigen?
Not in the beginning, so we can get the Legionella. Anything else?
And how does that correlate with the physical findings and the exam findings so far, Omar? What prompts that decision right now?
Because she's hyponatremic, she has like pulmonary complaints, concern for pneumonia.
Okay, we'll buy that up.
And she had like the water in here, the humidifier in the beginning. So
Yeah.
Yes. There's a lot going on, but yeah, maybe this is, you know, Legionella. And there's like an infection underlying it. Yeah. Okay. Also, if you're thinking, well, the hyponatremia, could it be related to anything else that you found in the labs? So now we know that there's someone, we don't know what her baseline labs look like. But there's someone coming in with edema, proteinuria, which seems to be like in a, you know, maybe nephrotic range, we don't know yet. You have hyponatremia and you have an elevated BNP. Low, or, you know, their CO2 is less than 4. Bicarb is really low.
Like it sounds like it, this is my opinion, it's more of like a renal issue making her acidotic, making her tachypnic. So I would go more down the road of some hemolysis or kidney disease versus pneumonia or like infection.
Could be, yeah. It seems plain. Towards us. Yeah, go for it, Tim. Yeah.
I guess, yeah, you have to correct for the BUN is really high, so she may not actually be hyponatremic. That's like spasmodically inactive. So
What is the risk with such a high BUN? We said they have normal platelets, but you have such a high BUN. You have someone that seems to be in some sort of renal.
like hemolytic uremic syndrome.
And at this point, your platelets could be this one. Go for it, Sam.
Yeah, I was just saying the platelets aren't functional at a BUN that high usually.
Is she presenting with any symptoms that you'd say, let's get this patient like to dialysis right away? Does she have any uremic symptoms at this point? And do you remember what those are? In her physical exam or neurologic exam?
So she doesn't have any signs of pericarditis or
Okay.
like cranial signs, like encephalopathy, sorry.
Yeah, sorry, but her bicarb is super low. Her creatinine is 15, BUN is 191. Should we take this patient, like, should I call renal right away? What am I doing with her?
I think like I couldn't find a reason where I wouldn't call renal right away when I see a creatinine of 15.
And when you call them, what's your question for them? Hey, I have a creatinine of 15, but she's breathing fine. She's on room air, no uremic symptoms. Like,
And the question is
I'd
going
be
to be
like,
whether
is there anything I'm missing that this patient requires emergent dialysis?
Okay. What were you saying, Victor?
the only thing that I wanted to point out is I don't remember the pH of the patient, so that could be one of the indications for dialysis at this point. But I don't see, like, she's not hyperkalemic, no signs of uremia, nothing otherwise. Like, she's not crazy overload. So 7.01 is like pretty low. So I think they're gonna dialyze her at this point.
At some point, yeah, we should get renal involved as soon as possible. But perhaps the question is, how do we proceed with management and diagnosis, which we as internal medicine doctors should already. And Dayo will show us what we have to do with this patient. But we should really have other questions. Okay, so we said the labs, we were going to get a Legionella antigen in urine. Go for it.
There are plenty of things that we can follow. I mean, we can work up the anemia, we can work up the proteinuria as well. So the anemia, we can get like a retic count and an LFT panel just to make sure that this is hemolysis or not. We can get a 24-hour collection or a microalbumin over creatinine to make sure like what range of proteinuria this is, and like further investigations for this acute renal failure that she's in currently.
Cool.
Good.
That's fantastic.
A lot of options. And so these are the rest of the labs, some that were gone for afterwards. A lot to take in. You have your LFTs at the bottom left, iron panel on top of it. You have some SCD screenings on the top right. We'll try to look at the protein at the bottom right. And then some more labs with haptoglobin, red tick, fibrinogen at the left as well.
So some of these were ordered by Victor. Dayo, why do you tell us more? Let's start with the anemia, perhaps. We'll split these.
So hemoglobin is 3.2, very low, very worrying. So you want to see if there was maybe a hemolytic anemia. So you want to get LFTs, liver function, to see what the bilirubin is like. And see if we notice that there's a raised AST, ALT. We also want to see what the liver function was like with lipase and amylase. And because there was damage to the red blood cells, thinking that to be low, we're going to get retic count, we want to get haptoglobin, LDH, see if there's any damage, see if there's any enzymes that were leaking out. Haptoglobin was actually increased. LDH was also increased as expected. The fibrinogen was at normal levels though. In case there's something with the clotting levels being wrong or being false, we got the factor V activity, which was decreased. And then in case you're worried of something else, we got Adams T13 activity receptor as well.
So it sounds like we have a lot of information that might even be confusing at times. And I'm not totally sure, I don't know what Dr. Julie thinks, but the lipase and amylase, maybe the ED was looking for some sort of intra-abdominal process. I don't know what else, or what kind of information we would get from this. But you mentioned it, right? Your haptoglobin is high, your LDH is also high. Is there any other event in which LDH might be high? So you add LDH in combination with the haptoglobin, and you were looking at hemolysis, right? So if it's not consistent with hemolysis,
There's type 2. It
You can
need
have it in-
answers as
May
well.
increase cell turnover, but it doesn't have to be hemolysis.
okay.
Like renal malignancy causing it as well.
Inflammation, okay. And the other 13 activity could be red herring. I don't entirely know how to, in this, how it would
Honestly, I
fit.
don't know why they got it, but
Yeah, that's a good question.
I like it doesn't fit with the picture. Everything else, like it's indicative of TTP, but nothing else indicates that. I mean, obviously the acute renal failure, but she's not in thrombocytopenia. She doesn't have a picture of hemolysis, like at least unless this is something atypical, I don't know.
And we know you said acute renal failure. This may be acute and perhaps chronic, a chronic process. And we know that chronic renal failure, this level may be low. Other than that, I'm not entirely sure. And you got a few antibodies here, and I see you have some viral panels that were ordered. What were you looking for, Dayo?
With the viral panels being ordered and the antibodies, we're ordering in case there's any vasculitis or any autoimmune process going on that could be attacking something like the kidneys or the blood cells to be causing all this mess. So, anti-MPO, PR3, usually some things you'll see in small cell vasculitis, as well as other HIV panels, Hep C, in case there's any cryoglobulinemia or any adjunct to any disease, showing that she was immunosuppressed and more likely to get infected.
Does she have any kids?
No kids.
Really, you don't know what to talk. Anyway, never mind.
Interesting question. All right, Dayo, you want to go keep going?
Is there any imaging or procedures you guys would do?
I was originally thinking like renal biopsy, because like good pasture would tie in good like the lung findings and the kidney findings, but then like the antibodies are negative. C4 is not crazy low, C3 is normal, so I'm not really inclined to do something that invasive, but definitely like a CT of the chest, because she did present with shortness of breath, and they did give her antibiotics for something that they saw on X-ray that we don't know. So definitely chest X-ray to start, and if concerning, CT of the chest.
Yeah, I like those answers. So to start, here's the chest X-ray. This is one we took. We never saw the chest X-ray she got before she came to the hospital. But on ours, you can definitely see some bilateral opacities, bilateral fusions concerning for fluid overload, pleural edema, pleural effusion, but also atypical opacities couldn't rule out pneumonia, clinically correlate. And then in terms of other imaging procedures we did, we added echo and ultrasound abdomen. The ultrasound abdomen showed small echogenic kidneys consistent with chronic renal disease, no hydronephrosis, and on the echo, it showed left ventricular cavity dilated, ejection fraction 25 to 30%, severe left atrium dilatation, and moderate to severe mitral regurgitation with pulmonary hypertension. 28 years old, 3 weeks of shortness of breath.
You're gonna ask for a
Victor can do the
volunteer?
summary.
Go for it, Juan.
I was gonna say that Victor can do the summary. He
Yeah,
has notes.
You can go.
Victor has notes.
I mean, it is the fairest option, Victor. You have your notes. You gotta help
I
out.
stopped taking notes after the history part, but anyway, I can try.
All right, so let's just focus on the basics, right? Patient demographics, so and
Yeah,
time
so
frame.
basically, young lady presenting with a subacute shortness of breath, exertional dyspnea, lower extremity edema, with crackles and on physical exam and lower extremity edema found to be anemic and possibly considered acute on top of chronic acute kidney failure, kidney injury. Honestly, there are a lot of things, like it's very hard just to put it into a one-liner when you're not like fully wrapped up around the whole thing.
You're doing a great job so far. So Dayo had a little bit more time to go over the case.
Okay.
Dayo, how will you summarize?
So I summarize it as a young Chinese female with the past history of unknown bowel disease, same with the subacute episode progressive dyspnea exertion, and 1 week of bilateral leg swelling, found to be severely anemic with deranged labs and bilateral haziness or bilateral opacities on chest X-ray.
Okay. Does that sound fair? Does it kind of bring, we don't know what the clinical syndrome is right now, but it does sort of summarize this case enough for us to continue. So Dayo, you looked for more information because this was a little confusing, even though it may all be related to one thing. You kept it broad.
Right. So working with this patient, it was a lot of things going on, a lot of things it could be. Her past history, she just said there's nothing there. She hasn't been to a doctor in 10 years. And then we noticed in her care everywhere, there was something from 2012. So we checked what it said and it gave us the information about her diagnosis. Are you ready to see? Like you all guessed, sclerosing IgA nephropathy. Pretty simple, right? We only knew because Care Everywhere was able to show and tell us that in 2012, she had a renal biopsy showing sclerosing IgA nephropathy with 80% glomerulosclerosis. It was also able to tell us that she had a previous diagnosis of rheumatic heart disease, which she said was her previous valvular issue, and that she was supposed to be on lisinopril and penicillin. Now, it also said in this report of hers that she was near end-stage renal disease of her kidneys with this IgA nephropathy, but there's no follow-up since then. It was just done 2012 in a New York hospital, and then there's nothing else ever since.
So wait, he couldn't tell you any of this?
She couldn't tell us any of this. She just said there's no past history, there's no previous surgeries, she takes no medication. She had no answer.
Pretty amazing someone doesn't remember getting a renal biopsy.
A bit interesting. And
Right.
we have to take patients at their words, but luckily we have Care Everywhere. It helps us when there's something there from previous visits. Otherwise, we would have done another renal biopsy, would have done much more workup. But this is what we're able to see, and we're able to try to work up what the cause was.
And it wasn't a language issue. She had no problem communicating.
She was communicating perfectly, speaking English perfectly, no barriers to communication.
Honestly, I'm not surprised at this point anymore.
Serious denial going on there.
All right, so we were happy that there was this. Her previous valvular issue sounds a bit vague, can be anything, and it was a rheumatic heart disease. And so this is a nice infographic algorithm showing if somebody has a biopsy-proven IgA nephropathy. What you want to do is monitor with the proteinuria, whether it's less than 1 gram or greater than 1 gram, and the systemic glomerular filtration rate. If it's less than 1 gram, we're happy with that. We're just continuing comprehensive supportive care and follow up. But if it becomes greater than 1 gram, that's when we consider going to a clinical trial or treatment with corticosteroids to target a lesser proteinuria. So as you continue getting follow-up, continue using lisinopril and her penicillin and taking some more steroids, who knows what ended up being this bad or what her condition would have been if she never came in. And so that leads us to the happy topic of nephritic syndrome. Nephritic syndrome, everyone's favorite topic, is an umbrella term for a bunch of different diseases that can affect the kidneys, resulting in hematuria, hypertension, decreased urine output, oliguria, as well as edema. Now, there's many different causes. I know Juan mentioned one called Goodpasser syndrome. There's one we're all familiar with, PSGN, post-streptococcal, our patient's own IgA nephropathy. There's different small vesicle vascularities that can affect the kidneys causing to it, benign familial hematuria, and different things like diffuse proliferative, commonly seen in lupus, and rapidly progressive, where it's just any cause can massively get faster, more aggressive, affecting the kidneys more. The issue with nephritic syndrome is, as you can see, there's many causes. Some are autoimmune causes, some are familial causes, some causes happen after infection, meaning unfortunately, anyone can get it. They're not that common, thankfully. In 2017, they're the 9th most common cause of death. Otherwise, there's many different causes, and the treatment for them are mostly similar, as there's nothing much you need to prevent it, but for treating it, you can usually use corticosteroids as well as supportive care. Now, people get this condition with hematuria, hypertension, urine output, edema, because everything happens to affect the kidney glomerulus the same way. Once the kidney glomerulus gets infected, it gets attacked, it's not able to do its function properly, and its function is to help keep elements into the urine to be able to release. When it doesn't function properly, protein and other things can get leaked out, and this leakage means less urine is going to be created. It means blood itself can leak out, leading to hematuria. It means that more fluid is going to have to come into the kidneys to make up for it, so it releases more enzymes, leading to hypertension to squeeze the blood, as well as edema from sometimes proteins leaking out, such as albumin, leading to hypoalbuminemia, and patients can even be in a higher thrombotic state from proteins, coagulation proteins being leaked out as well. So they all have the same presentation, showing that this is damage to the kidneys itself happening. Now, for most of them, you want to see what's causing this damage to the glomerular basement membrane. So you have to do biopsies as well as microscopy. There's different types of microscopy, like the light microscopy we use for the H&E stains. This is using light, so we can actually see what GBM looks like, to see what general damage looks like, to see how it's functioning. And then electron microscopy, which is able to use electrons, which is smaller than light wavelengths, to go deeper and get more clear pictures. We use this so we can see what's actually happening, to see if there's any immune complex depositions on glomerular basement membrane that could be causing damage to the GBM as well. And something to point out in the lab that we got, as you can see, the C3 is low, which is common in people with autoimmune complex depositions. One of the reasons we got all the STD panels is we know that for glomerulonephritis, HIV can cause it, hepatitis C can cause it, cryoglobulinemia can cause it. So we want to see if there's any causes for there to be damage to the kidneys. That's what the thought process behind it all. And with the Adams T13, there's usually a pentad of renal failure, confusion, neurological failure, anemia, schistocyte thrombocytopenia. And she didn't quite fit the pentad, but we wanted to make sure it wasn't TTP because that's a severe issue needing plasmapheresis. There's also other things that could cause it, like HUS and DIC, so it's also helping to rule all of those out as well. And we knew she had a leukocytosis of 21. Sometimes it's something you can see in massive systemic infections. She had no fever. There's no illnesses. There was anywhere of UTI, but it's something we just had to wonder why that was there as well. What if there's any sepsis, like you all were wondering, that was causing this whole presentation. And so for the illness script, the demographics, there's a variety of causes of different demographics affected, but the main pertinent symptoms and signs you'll see is nephritic syndrome, which is oliguria, edema, hypertension, and hematuria. Triggers can be bacterial infections, PSGN, viral infections, autoimmune disorders, or just immune complex deposition. Mechanism, like I said, is damage to the glomerular basement membrane, so it can't function, and so everything gets lost, and it has to overcompensate, leading to the symptoms you see. And management for them is you want to just be able to do UA, see if there's protein, see if there's blood, see if there's any other cause of kidney damage, check what the complement levels are, do a biopsy if you can, and the microscopy to confirm what the damage has been. And in terms of management treatments, conservatively, you can do water, make sure they're highly adequate, and do a protein restricted diet, so not getting too much protein. And then medically, you try to treat the symptom itself rather than the symptom it's causing for most of the part. So for the high blood pressure, you want to give them ACE inhibitors or ARBs. That also helps with the proteinuria as well. For the diuretics, for the edema and the hypertension. And then if it's any autoimmune process, you want to do immunosuppressive therapy, plasmapheresis, or renal replacement therapy. And for the particular patient herself, she was transfused in the ED, it was an AC secreted, and shocker, went straight to the NICU for end-stage renal disease, congestive heart failure, hyperkalemia, and severe anemia. She had a bronchoscopy that showed signs of diffuse alveolar hemorrhage, likely from pulmonary capillaritis, which can be a rare side effect of IgA nephropathy. She spent a week in the ICU, then 10 days on floors, and was started pulmonary steroids, torsemide, Isordil, a lot of other medications. So she came into us saying she has no past medical history, takes no medications, and then left us being on 12 new medications. She got a perm CAT doing Monday, Wednesday, Friday dialysis, got a cardiac MRI, and will now be following up with cardiology for advanced heart failure. But she's doing better now. She's since been discharged and was seen in clinic. So I'm glad we helped her. I'm glad this is going to be in care everywhere for the next time she goes to the hospital. And so that was her course in the hospital with us. Thank you.
Can I ask, what did the cardiac MRI change?
The cardiac MRI was done outpatient, so the advanced heart failure team knew how they could further monitor and manage her. When they did it outpatient, they found it went down from 25 to 30 to 20 to 25%. And so they're just continuing on upload reduction, doing diuretics on days she doesn't get hemodialysis, and they were just considering in the future what they're going to need to do for her.
And they needed a cardiac MRI to know that?
Perhaps you're looking at alternative diagnoses. You want to rule out other cardiomyopathies. I don't know if the cardiology interns in the group can answer that question, but I know that in someone with such a rapid decline in their EF, being a young patient, I mean, it definitely, there was like a couple other alternative diagnoses here, but at least that's the explanation we get sometimes from our cardiology group.
I think sometimes they just have a new test and they like to order it. They're kind of famous for that, when it's giving you the same information that they already got from an echo. So I get it if it was like sarcoid or something like that, but I'm just unclear why this would require that. So it'd be interesting just to ask them that specific question. Why was this imaging modality done specifically for this person? Since it really didn't seem to change anything.
Not really.
So I feel like, sorry, the service about the patient actually not knowing when she's 19 when this happened, like according to the Care Everywhere, was there any further information, like even the family or someone that kind of knew anything that had happened in the medical history? Because I feel like that was a big disservice of whoever was taking care of her at that moment, or like in terms of delivery and communication of what was there. So like, did we find out what happened, or there was just no, she just kept on saying that she didn't remember or know about this?
She came in with her fiance and he had no
Uh-huh.
idea about anything either. He also thought she had no past medical history. She denied any past medical history, any past surgeries. I talked to her, resident talked to her, attending talked to her, multiple teams talked to her every day, but there was just nothing else she knew of, nothing else she remembered.
Yeah,
That would have made her like 8 when that happened, right? If she was only 19 now.
She's 28 now and she was 19.
So
yeah, the report said 19-year-old.
you can remember things from 19. That's a little weird.
I don't
That
know.
goes to show, even if there's no language barrier, you can still have patients with very poor health literacy and like their family's not being involved. You miss out important information. If she had followed up, would she have ended up in the emergency department with, chronic renal disease? And heart failure?
Yeah, it's an interesting, just let because I do a graduate school course, teach, and yesterday's session was on health literacy. And so this is a very, and I just find it amazing that, but again, not surprising, I guess, but I know it was 10 years ago, but it's just amazing that, and again, it comes down to whoever was communicating the information to her.
Right. Mhm.
It comes down to whoever delivered it. And no matter what, if the person was in denial, maybe it wasn't retaining the information, or their literacy or language level, somehow someone wasn't able to even connect with this patient to understand, like that there was something at least that needed to be followed up, and that her kidney. Yeah, I just feel it's a disservice to what had happened, I guess, 10 years ago.
And Nadia, you were looking at reports and notes, and all he could find in the system from what you told me was just a report of her conditions and her
they had
biopsy
this
results.
workup. She had a whole bunch of blood work, so you would think that, why am I getting all this blood drawn?
Someone had to explain. Exactly.
So I'm just, it's more like the perspective that we were talking, and these were graduate students, and they were kind of like amazed that, and I'm just like, and we're in a different level, and some of it came down to time and not having the time, or the language, and I'm just like, like that's actually not correct, because you can make the time even if it's just multiple visits with the patient.
Also had a needle stuck in her back, so there is something not in with the story. I don't care how literate she is. She had a needle stuck in her back.
Oh no, and then the family gets involved. Where are you then get the family to like understand. That's what I do if I feel like the patient may not be understanding. I don't know. I just, it's more more from a teaching point and communication delivery.
I mean, you also think like she just didn't want to deal with the diagnosis at 19, right? who wants to deal with end-stage renal failure at 19? That's a horrible thing to have to, deal with at any time. But when you're a teenager, planning your life, I could see how she might want to just forget about it because she was feeling okay, I guess.
And didn't go see a doctor anytime in between, because you would think that her renal function or something would have been off in these last 9 years. But yeah, so that's a 19-year-old, maybe went to college and just forgot about everything. I don't know. I'm just, it's more of a communication that it just.
That's the case, I have to sign off to meet with the resident.
Yes, and I have ID conference. But you did a great job, Di. I was listening and watching everything. I don't like to be distracted, but I was paying attention. You did a great job.